Good morning, everyone, and welcome. So, at the outset, I would like to thank Organizing and Scientific Committee, Iracon 2022, for such wonderful sessions. Talking about the osteoporosis always considered one of the very important cause for the mortality and morbidity in the elderly population. Rather, in few of the studies, we know that it has been found that it is ahead of even the diabetes and the blood pressure as a cause of mortality in the elderly population. But as an internist and rheumatologist, when we see the osteoporosis is almost like an elephant in the room. Not very controversial, but definitely often neglected. Why I'm saying this, if we talk about the epidemiological data from India, we don't have much data, but we did an audit in 2010 in Hinduja Hospital, in which we surveyed the patients who were on the steroids for more than 5 milligram for more than 3 months. And just prospectively, we reviewed that how many patients are receiving the proper prophylaxis for osteoporosis. And it was surprising that only 25% of the patients were on the proper doses of osteoporosis prophylaxis. Rather, worst part was that almost 20% of the patients were not receiving any calcium supplements, even the calcium supplements. So the data was from the rheumatology OPD, neurology OPD, and the orthopedic and the medicine OPD. So this was the data from the Hinduja Hospital, which is considered one of the tertiary care hospitals in India. So we can assume or predict what can be the practice scenarios in the other part of India. So talking about the causes for the osteoporosis, we all know the routine causes like the sex, smoking, alcohol, lack of exercise. But inflammation plays a very important role, and the rheumatology practice, we know that other than the systemic inflammation, we have a localized inflammation around the joints also, which also play a major role in the bone weakening or the bone resorption. Sarcopenia we often don't discuss, but sarcopenia and osteoporosis are considered to be the major causes for the fragility or the frailty syndrome, which is again one of the major causes for the osteoporotic fractures. So the further discussion our speakers will take on from here. So I'm inviting the chairpersons, Dr. Mala Bhambani. Dr. Mala Bhambani is a senior practicing rheumatologist in Mumbai for more than 10 years. And Dr. Pooja Khosla. Dr. Pooja Khosla is a senior physician, Professor Khosla at the Sir Gangaram Hospital, Delhi. So they will take over the session from now. Thank you.
Good morning, everyone. We'll be having a discussion on osteoporosis, and the first lecture is Inflammation-Induced Osteoporosis, an Overlooked Entity. So I request Dr. Brigadier Chattopadhyay from Lucknow to come and deliver this.
Good morning to all of you. Good morning, chairpersons. At the very outset, let me profusely thank the organizers for giving me this opportunity to discuss things related to this topic, today's topic, with this knowledgeable audience. I have been given this responsibility to speak on inflammation-induced osteoporosis, and it is considered to be an overlooked entity, which indeed is the case. This is my mandatory conflict of interest, which has no bearing on today's talk. Now, in the next 15 or so minutes, this is what you are expecting to know from this or hear from this talk, is that the generalized mechanism of bone loss due to inflammatory diseases and the best approach to protect bone loss in rheumatoid arthritis in India. We will give an example, and that, continuing with that example, I will give our research regarding a drug candidate which is, we think, has relevance in Indian scenario. Now, overall mechanisms of bone loss in inflammatory disease, I have covered here. I'm going to talk on these 3 disease conditions. The reason these are rheumatoid arthritis, IBD, and COPD. The reason being that the most of the skeletal data have been available from these 3 disease conditions, considering all the inflammatory diseases. And there are common mediators such as interleukin 1, 6, and TNF-alpha. And there are some unique mediators in case of IBD, including 12, IL-12, 21, and 23. What these mediators do is that they work on or act on both osteoblast and osteoclast. In case of osteoblast, they, through their cognate receptors, they first of all quite quickly activate ROS production, and the ROS production then induces Rankel production, and this Rankel production is concurrently happening with suppression of osteoprotegerine, which is the decoy receptor for rank ligand. And as you know that the Rankel to OPG ratio is one of the major determinants or the most important determinants of osteoclastogenesis. Alongside, it is suppressing Wnt pathway, which is osteogeny, by stimulating Wnt inhibitors such as, or Wnt antagonists such as sclerostin and DKK1. Together, this rank ligand will bind to its receptor rank, which are expressed in osteoclast progenitor cells, leading to their fusion to mature osteoclast, more vigorous and more in number, leading to bone resorption. Now, the risk factors for osteoporosis in inflammatory diseases are again common and some unique. In case of RA-related risk factors, the common are in all these 3 are inflammation and glucocorticoid use. In case of RA-related risk factor is immobility and sarcopenia, which increases the propensity for fall. In case of IBD, it is malabsorption of vitamin D and K, as well as calcium, as well as malnutrition, and leading to low BMI and increased risk of fall, leading to enhanced osteoporotic risk and fracture risk. Now, when you superimpose or merge it with conventional osteoporosis risk factors, such as increasing age or hypogonadism or previous fragility fracture, you have again further heightening of osteoporosis and fragility fracture. Now, intervention-wise, for RA and IBD, the guideline is there. The first line is oral bisphosphonate, and the second line, the first line is minus 2.5 without any fracture, and the second line is generally these very aggressive therapies, zoledronic acid bisphosphonate, which is the long-acting bisphosphonate, then denosumab, which is a rank ligand human antibody, and teriparatide, particularly in patients who have fractured during the first line. Now, as you know, and you most probably are also using biologic DMARD, which are in increasing use these days. They're very targeted, safe, and it has bone protective effect. So this is a list of the targets such as TNF-alpha, IL-1, IL-6, IL-12, 23, CD20. Now these have been targeted in various ways. Number one is targeted by monoclonal antibody, targeted by chemical inhibitors, or targeted by chimeric proteins. Now these bold font drugs are those that have been tested, or trials have been done in either RA and IBD, and the bone mass data have been obtained, and these drugs suggest that it has significant bone protective effect. Now, so far so good, but then if you see these conclusion from a meta-analysis published in 2015, it says that the standard or high dose of biologics with or without conventional or traditional DMARD such as methotrexate are associated with increased risk of serious infection compared to traditional DMARD. And that is where we think that the Indian scenario becomes relevant, serious infection due to these drugs. So we have raised this question in our research program: is it possible to inhibit arthritis, protect joint and bone while not suppressing systemic immune response? So that was the challenge we took. And to answer that challenge, what we did is to review the literature regarding our old dirty friends, which is helminth. So these helminths are infecting humans for hundreds of thousands of years, and they're the most successful parasite. I'm talking here about parasitic helminth. They're the most successful parasites concerning human infection, because currently 1.5 billion people are infected with these helminths, be it a variety. It means flatworm, roundworm, hookworm, fluke. Now, these helminths, as you know, that heavy burden of the helminth, particularly for children, is extremely detrimental, and it can also even cause mortality. But a low dose of helminth can be, or low burden of helminth may not be pathologic or even commensal to the host. And the reason why it is so is because the way it acts by the excretory-secretory product of helminth, the ES product. It stimulates a typical M2 phenotype, and M2 macrophage phenotype leads to activation of Th2 cells, immune system. And Th2 immune system, as you know, is the regulatory. It antagonizes the Th1 highly inflammatory system. So, in one hand, it induces Th2 response by M2 macrophage phenotype, and on the other hand, it stimulates the dendritic cells to produce immunosuppressing cytokines such as IL-4, IL-10, and TGF-beta, and at the same time using these MDSC, which are myeloid derived suppressor cells, it stimulates INOS and ROS to kill the Th1 responsive cells. So taken together, that is how it suppresses the immune system for becoming super aggressive. And then there is extensive studies showing that there is inverse association between prevalence of many helminth species and autoimmune diseases. So what we did is that we then focused on specific helminth related to inflammatory activation. And here we found liver fluke, Fasciola hepatica. It produces a defense molecule, which is the name, which is quite a long acronym, but don't have to remember the acronym. It inhibits this protein. It is a secretory 8 kilodalton protein. It inhibits LPS-induced inflammatory cytokine production from a variety of inflammatory cells, And the cytokines that are inhibited include TNF-alpha and interleukin-1. And this protein is, interestingly, structurally very similar to a human antimicrobial protein, which is cathelicidin. Now, these parasites, the liver fluke, they also produce cathepsin L that, while secreting this full-length protein, also produces a C-terminal cleave protein, which is a 34 amino acid protein, along with that. So it is co-secreted by the helminth, and this C-terminal protein binds to macrophage membrane, gets internalized, and inhibit endosomal acidification. And concurrently, it inhibits the antigen presenting ability and NLRP3 inflammasome activation of the macrophage, leading to immune suppression. So we did this experiment first, that we took splenic macrophage from mouse and sensitized them with rank ligand to induce osteoclastogenesis by doing the trap staining, and and you can see that there is a concentration dependent fall in the osteoclast production in the presence of this peptide. And when we did this lysosomal acidification experiment using lysotracker, and you can see that with rank ligand, this is the response, and in the presence of the peptide along with the rank ligand, the lysosomal acidification is significantly attenuated to the extent that at highest concentration there is hardly any signal available, fluorescence signal available. So these studies indicated that this is an anti-osteoclastogenic. Now what happens to osteoblast? It does nothing to osteoblast proliferation, it does nothing to osteoblast differentiation, but it significantly attenuates the rank ligand production from osteoblast induced by IL-1 beta. So it is inhibiting the rank action on osteoclast as well as inhibiting rank ligand production from the source. Then we used a mouse model, which is a DBAJ1 mouse model. We induced experimental arthritis by giving type 2 collagen, and along with the booster we gave them the peptide every alternate day, subcutaneous, at the rate of 2 microgram per kg. And then at the end of the study, what we found is that the severity disease score, this is the red one with the control animal, the disease animal, and in presence of the peptide, it is significantly attenuated. And then we did the joint histology, and the take-home message of the joint histology is that the presence of peptide mitigates the joint damage, the PANA score, and more importantly, the proteoglycan score. You can see that the proteoglycan staining in the control healthy animal, this is the disease animal, and this is the peptide receiving animal. So the entire joint was very well preserved. Then what happens was that the subchondral bone, the femur and tibial subchondral bone was studied. And again you can see that in the CIA, where the disease condition, the bone is terribly eroded at the epiphysis, and it is maintained by the peptide in these animals. And so the BMD and bone volume in both cases were maintained by the peptide to the healthy control level. And then at the same time we found that if we take these joints and do the measurement of mRNA for the osteoclast markers such as tartrate resistant acid phosphatase or cathepsin K, both of them were significantly elevated with the CIA, that is the disease condition, and the peptide given to the diseased animal brings it back to the normal or even better than the normal. And the rank ligand to OPG ratio, which is a determinant of osteoclast formation, in these bones were super high with CIA, and the peptide was completely maintained it to the control level. So which means that what we found in vitro was completely reproducible in vivo in the CIA model of arthritis, rheumatoid arthritis. But then, when we studied what happens to the effect in the serum, and when we compared the effect in the serum systemic level as well as the joint level, what is interesting, what you will see here, that we measured the synovial level of TNF alpha and IL-17 in these groups of animals. And you see that CIA-induced TNF alpha as well as IL-17 was completely mitigated by this peptide. But then, if you look at the serum data, what you will see is that TNF alpha increase and IL-17 increase was not mitigated by this peptide, suggesting that the effect is very much joint specific. It does not suppress overall immune system. And then on the right-hand panel, it is the immunoregulatory Treg cells were studied, characterized by CD4 plus FOXO3 plus, and the immunoregulatory cells population was significantly inhibited in CIA, but maintained by the peptide, suggesting that the Treg function is very much effective in these animals that are receiving the peptide, although they are arthritic. So, to summarize the data, we have discovered a specific fragment of a protein secreted by the liver fluke, a parasitic worm, that protects articular cartilage of joints in experimental arthritis mice model. Besides, this protein fragment also prevented joint bone from being eroded, but the peptide is doing these two beautiful things without affecting body's overall immune function. We published this paper, and the lead author, Yasir Akhtar Khan, was a DST Inspire Fellow, and we acknowledge Department of Science and Technology and CSIR for generous funding. Thank you so much. Question is?
Thank you, Dr. Chattopadhyay. So our next speaker is Missed Opportunity, Sarcopenia, a crucial bone health related issue in rheumatology. And I request Dr. Sukhbir Uppal from Mohali to come and deliver the talk.
Thank you very much. I'm grateful to the organizing committee, especially Devashish, who gave me this topic. And it's good to be back on the IRI platform after a long gap. The aim of my talk today is to increase our awareness to sarcopenia, and more importantly to something known as osteosarcopenia, and how these conditions relate to our daily rheumatology practice. These are my key references, but I wish to point out that a lot of research is going on in this field, although still the literature is at a nascent stage and lots of work remains to be done. Sarcopenia is defined by the European Working Group for Sarcopenia in older people as the loss of skeletal muscle strength, function and mass. So there are three components here: muscle strength, muscle function and mass. They have also added another line that it is associated with a range of adverse physical and metabolic outcomes in terms of disability, impaired quality of life, morbidity and even mortality. The Asian Working Group has also adopted a similar definition. They also focus on mass, strength and performance, but have used slightly different cutoffs used for the diagnosis of sarcopenia. If you see the life course of muscle strength, the muscle strength starts to decline in a linear fashion from the 4th decade of life, and it can dip below the threshold of low physical performance or even below the threshold of disability. What about India? I found one study done in the geriatric outpatient clinic of CMC Vellore, and they found a fairly high prevalence of primary sarcopenia of 39%. And interestingly, sarcopenia was twice as common in men as in women. As far as rheumatoid arthritis is concerned, the prevalence of sarcopenia is high. I found a lot of studies on rheumatoid arthritis and sarcopenia, 15-20 of them. But if you have a pooled estimate, it comes to about 33% compared to 10% in the general population. So it's fairly high prevalence of sarcopenia and rheumatoid arthritis. And there are many risk factors which have been implicated in many of these studies, but usually they all mention functional limitation, inactivity, fatigue, and high inflammatory markers. And we all know that TNF-alpha, IL-1, IL-6 do promote protein catabolism in muscle. As far as other rheumatic diseases are concerned, they are also prone and predisposed to developing sarcopenia, and as explained by the previous speaker, the underlying pro-inflammatory state not only affects the bone but also affects the muscle. And also there is a decrease in muscle use due to inactivity and pain. For example, in lupus, the prevalence is described overall as about 9 to 10%. Spondyloarthritis, more, about 22%, but different studies give different figures. And men with ankylosing spondylitis have significant reduction in the skeletal muscle mass and also associated bone loss leading to osteopenia and osteoporosis. Scleroderma is significantly associated with sarcopenia, and even osteoarthritis due to inactivity and obesity and underlying inflammaging is associated with sarcopenia. So now we come to another term, osteosarcopenia. This is an underappreciated musculoskeletal syndrome which is defined as the presence of osteopenia or osteoporosis and presence of sarcopenia. So we need both the conditions, osteopenia, osteoporosis and sarcopenia. What happens is that at the 6th decade of life, there is a progressive decline in the bone mineral density, 1 to 1.5% per year, muscle mass, again 1% per year, and especially in the muscle strength of 2.5 to 3% per year. And now muscle and bone are recognized as interacting tissues, the so-called muscle-bone unit. And there is a strong bidirectional relationship, as I will show you, between these two components. So osteoporosis strongly increases the risk for sarcopenia, and sarcopenia strongly increases the risk for osteoporosis. For example, those with sarcopenia have a 5-fold higher risk of developing osteoporosis. So they are linked together. And even more importantly, osteoporosis and sarcopenia share common risk factors. This slide shows the muscle-bone crosstalk involved in the pathophysiology of osteosarcopenia. It's a complicated slide, and there are a myriad of factors which may explain the pathology. I will not go into all the factors in the interests of time, but I would like to draw your attention that sarcopenia and osteopenia aggravate each other, and there are positive and negative feedback loops in this pathogenesis. For example, myokines produced in the muscle modulate bone remodeling. Myostatin increases osteoclastogenesis, whereas follistatin and irisin prevent bone resorption. In the opposite direction, we have osteokines like osteocalcin and connexin 43, which are anabolic and catabolic for muscle respectively. With aging, fat accumulates in the bone marrow as also in the muscle, and the fat secretes adipokines, and these adipokines also cause apoptosis of osteocytes and of myocytes. What are the clinical outcomes in osteosarcopenia? Because predominantly of the sarcopenia, there is an increased risk of falls, a very high odds ratio. And because of the osteopenia or the osteoporosis, there is an increased risk of fractures. And especially in those with hip fractures, there is an increased risk of mortality of an excess of about 84%. There are many other consequences, and there is a high personal, social, and economic burden when osteosarcopenia is left untreated. These patients have an impaired ability to perform activities of daily living, and there is an association of osteosarcopenia with cardiac disease, respiratory disease, cognitive impairment, and of course there's a lowered quality of life. Loss of independence may happen, or even the need for long-term care placement like a nursing home. When confronted with a patient of rheumatic disease in which you are suspecting osteosarcopenia, it's important to screen for the degree and extent of underlying inflammation by study of the inflammatory markers, etc. Assess how much glucocorticoid, if any, is being used, the duration, the dose, because that's an important factor. Assess for vitamin D deficiency, low protein intake. You may assess for other factors also like hyperparathyroidism, other vitamin deficiency, hyperhomocystinemia, etc., renal dysfunction, and check vitamin D levels, calcium, and testosterone levels in men may be an important cause of osteosarcopenia, hypogonadism. This is the Asian Working Group algorithm. If you focus on the right side of the slide, it's a busy slide, sorry, but I'll just give you the highlights. In the presence of a rheumatic disease and suggestive symptoms like falling, slow walking, fatigue, difficult rising from a chair, etc., and if the calf circumference of the patient is less than 34 centimeters if male and 33 if female, you should have a suspicion of sarcopenia. Then muscle strength is tested by hand grip using a dynamometer, and there are cutoffs, and then physical performance is assessed by walking, how fast the patient can walk. And finally, the appendicular skeletal muscle mass is checked either by DEXA or by bioelectrical impedance. Bioelectrical impedance is what these scales use. When you stand on the scale, you get total body fat, total muscle, what is the bone content, everything comes. It's by passing an electrical current, they get these values. In sarcopenia, one should have a reduced appendicular skeletal mass plus either low muscle strength or low physical performance. And if it's a severe case, all three will be present. This is another questionnaire which can be used. It's user friendly. You can the patient can fill it up fast if he is literate, and a scoring is done to assess physical function. This is the handheld dynamometer, even available on Amazon, which assesses the grip strength. Actually, the grip strength and the gait speed are two best validated methods for assessing sarcopenia. And then there is another short physical performance battery test which can be done. I won't go into the details. Coming to the management of patients with rheumatic disease and osteosarcopenia. Tocilizumab, being an anti-IL-6 agent, has been shown to be associated with increasing muscle mass among patients with rheumatoid arthritis. Contrarily, the other drugs, the TNF inhibitors, like adalimumab and etanercept, have not really been shown to be effective so far, but more evidence is required. Although theoretically, even the conventional synthetic DMARDs, the anti-TNF, the JAK inhibitors, should be useful because they suppress inflammation, and inflammation is a predominant cause of osteosarcopenia. Steroids have conflicting effects. If there is severe inflammation, they prevent sarcopenia. But otherwise, the overall effect is pro-myopathy. I mean, we are all familiar with steroid myopathy, even in doses of 3.25 milligrams per day. And also they cause bone destruction and osteoporosis. So steroid use should be absolutely minimized or stopped as far as possible. Denosumab has shown promising effects on muscle and bone health. Studies have compared this with intravenous zoledronate, and denosumab has shown improvements in muscle mass and muscle strength. Testosterone is theoretically attractive for men with hypogonadism and low testosterone levels, but the problem is there's an increased risk of prostate cancer and virilization in women and increase in cardiovascular events. Myostatin inhibitors are being tried now, and bimagrumab is an anti-myostatin receptor monoclonal antibody and has shown good results, but still in the investigative stage. Non-pharmacological interventions are also extremely important. The first one being exercise. And exercise causes augmentations in muscle and bone mass, as well as muscle strength, balance, functional capacity. And the type of exercises should include a mix of resistance exercises and balance exercises and aerobic exercises. Protein intake should be optimized. It can even go up to 2 grams per kilogram per day. Vitamin D levels should be in the higher normal level. Calcium supplementation. Creatine has been shown to improve muscle strength and mass in the dose of 3 to 5 grams. And as far as protein supplementation is concerned, whey protein is considered a very good option. It contains a good amount of leucine, which is very anabolic for the muscle. Vitamin E is reported to be beneficial for steroid-induced myopathy. And patients should be encouraged to stop smoking because smoking is directly toxic to the muscle and to the bone. So these are the general strategies: resistance training exercise, balance exercises, and all the other options that I have outlined, and they will result hopefully in increased muscle mass, strength and balance, and reduce the risk for falls. And on the other hand, they will also increase the bone mass and strength and reduce the risk of fractures. So the practice points are that we have established criteria for diagnosis of osteoporosis and sarcopenia, and if you find one, try to look for the other. And also consider other factors which may be playing a role, like vitamin D deficiency, glucocorticoid excess, and inflammation. Lifestyle factors include increased physical activity, inadequate protein intake, and vitamin D deficiency remain very important in the management. Thank you for your attention.
Okay, thank you, Dr. Chattopadhyay and Dr. Uppal. The question answer session is now open.
I think there are no questions.
Any questions? So this session is closed now. The next speaker, you will be giving the...
So we have a very interesting topic, brainstorming a big doubt. When and how do I treat osteoporosis in a steroid-naive young patients with autoimmune rheumatic disease? And I request Dr. Avinash from Vellore to come and deliver the talk.
Good morning, everyone. So I am Avnish Jha from CMC, and today my topic is very interesting: when and how do I treat osteoporosis in steroid-naive autoimmune rheumatic disease patients? So first of all, disclaimer: there are no guidelines till date on this topic on those who are not on steroid and having autoimmune rheumatic disease, and especially in youngsters who are less than 40 years. We have frax tool beyond 40 years, but nothing less than 40 years. So whatever I am discussing is on the basis of discussion with the experts in the field, and also adapted from GIOP guidelines, which are present already. So burden of disease, there is already established data on rheumatoid arthritis. There is increased risk of osteoporosis, and not just that, there is increased risk of complications and fractures. And same with ankylosing spondylitis and SLE patients. These patients just don't have more osteoporosis, but they also have more complications. However, all of this data may not be very reliable because they are mostly retrospective and registry based. The risk of bias of these studies is not well discussed in the meta-analysis that I have actually put up. The prospective data from cohorts from our country is probably the need of the hour. So the risk factors for osteoporosis in autoimmune rheumatic diseases, there are traditional risk factors which we already know of, but in disease-related risk factors, disease duration, the disease activity, the risk of fall, especially with our patients having arthritis, the risk of fall is higher. Medication which are associated with bone loss are also important. RA-specific factors which have been already established are presence of anti-ACPA, presence of erosive disease. SLE-specific factors which have been proven in trials is lupus nephritis presence of higher levels of oxidized LDL, hormonal abnormalities including early menopause, and presence of certain antibodies like anti-Rho has been specifically associated with bone loss in SLE. Ankylosing spondylitis, not just the duration of illness increases the risk of osteoporosis, but during this time it may also be difficult to ascertain osteoporosis because of presence of syndesmophytes. So these are the major guidelines on osteoporosis. When do we do a BMD? But there is no inclusion of autoimmune rheumatic diseases as a risk factor in any of these guidelines. So they don't really apply on our patients. So we have to individualize. So, but we can use this ACR 2017, which has now been updated in 22, as a framework maybe, and then look at our patients who are less than 40 years. If they have a generalized risk factor, or if they have a disease-related risk factor, maybe they need a BMD. Those more than 40 may be a frax tool usage, which is good, but may not be optimal all the time, as it does not include the dosage of steroid and the duration of RA. And maybe we can use, instead of RA, SLE is there, then that also may be used as a risk factor in the frax tool. So how do we stratify these patients? So again, this has been adapted from the GIOP guidelines. So we can probably make them into 4 risk categories. The low risk, who have a Z score, remember this is Z and not T score, of less than -2. They probably need only general measures. Moderate risk are those between -2 and -3. They may need regular monitoring. Is there a role of doing a trabecular bone score in these patients? Maybe. We don't have an answer exactly. High risk are those with a Z score of less than -3 and a more than 10% drop in the BMDs serially done. A very high risk are those who have already had fractures recently or who had fractures on therapy. So when do we treat? So what is the role of trabecular bone score? This is a new thing which is coming in densitometry, and this actually assesses your bone quality rather than quantity, and a TBS value of less than 1.2 has been established to be telling the risk of fracture in other type of osteoporosis. Now there is data being generated on ankylosing spondylitis patients where your BMD scores might not be useful because the values may be high, abnormally high, which is not the real value of the patient because of syndesmophytes. And also in SLE patients, that TBS score can actually predict risk of fracture even in osteopenic patients and not really osteoporotic patients. So when do I treat them? Low risk, just keep them on follow-up, general measures. Moderate risk, if you are planning to treat them, For example, if they have a very low TBS score or if they have high risk factors, give them oral bisphosphonates probably. High risk patients, probably first line will be IV bisphosphonate, and very high risk are those where the risk, the use of anabolic agents comes into picture. Today, in today's time, we have predominantly only teriparatide in our country, but romosozumab is coming up, and also denosumab has a specific niche of patients where we should probably think of denosumab, especially in those with CKD or those who cannot tolerate bisphosphonates. And so how do we follow them up? We have to do, so ISCD guidelines tells that we should do BMD only if it is changing your practice. So typically after 1 year when you start therapy to see the, how it is working, the medications, and also once in 2 years in those with moderate risk or those who are stable on osteoporosis treatment. There is also a big big role of biomarkers which is coming up. Now it is part of guidelines actually to do bone formation markers and resorption markers, specifically if you are going to use anabolics. So they also have other roles. The other roles are that other than those who are not getting therapy, you are just following they are osteopenic, then there may be a role of doing these markers. Also it helps in compliance adequacy, and also if you are giving drug holiday to patients with bisphosphonate, helps when to restart therapy, when does your markers start rising. So sequential therapy, always remember bisphosphonates are the only one which are retained in the bone, rest all are short acting. So everything which you are giving before has to be followed by bisphosphonate, and this has been proven in trials for denosumab as well as romosozumab. So how long to treat? Ideal would have been to normalize the BMD and stop the treatment. However, it is not always possible. Teriparatide has now been extended up to 3 years according to the FDA guidelines, however still 2 years in Europe because of the risk of osteosarcoma that they have found in rats. And also the recurrent use of romosozumab is being studied. So now bisphosphonate drug holiday, do we really need to give it? So actually our data says that for preventing one atypical femoral fracture, we are having more than 15 to 100 typical osteoporotic hip fractures. And also, there may be, and the benefit actually goes on up to 6 years to 9 years in patients' BMD improvement. However, the most BMD improvement happens in the first 3 to 6 years. So if you want to give a drug holiday, you still should do a BMD and bone markers for follow-up. Special scenarios in pregnancy patients, you should not, none of the treatment is actually safe and should not be treating osteoporosis ideally during pregnancy. If you are planning to treat someone so then you should advise them against the pregnancy. In children, there is newer studies coming up that IV zoledronate is working better than oral. So generally you don't need to treat them, but if they are very high risk or if they have already had fracture, then you might have to treat them. Then bisphosphonate is the drug of choice, IV more than oral, and use of PT adrenaline should not be done in children because it can cause early epiphyseal fusion. So conclusion, there is a great need of data-driven guidelines for osteoporosis treatment and management in autoimmune rheumatic diseases, especially the young section, but we don't have them. Till then, we may assess individual patients' risk of osteoporosis and fracture and treat accordingly. Thank you so much for your patient listening.
Thank you, Dr. Jha. Now, to conclude the session, Dr. Pooja Khosla will give words of wisdom.
I totally agree with Avinash that this category of patient where the patient is less than 40 years and has autoimmune disorders and not been exposed to steroid, it's very difficult to, because there are no guidelines. And, sorry sir, you want to say something? So this has to be individualized case-wise, and we are extrapolating the guidelines of either GIO or in pediatric population, or we are converting the guidelines which are for elderly to a younger population. And we are assuming that they are still not treated with steroids. So this category needs more proper study and formulation of guidelines, because they will have a longer duration of treatment, and we already are not clear. After 9 to 10 years, bisphosphonates have to be given or not. So these are still thoughts which we should keep in mind while evaluating these patients. Yes. Please come on stage.
Done an excellent recap of the existing literature. A couple of points, quick points regarding denosumab. Once it starts, it cannot be stopped. If you stop it, there would be a tremendous vigorous bone loss, or you can switch them to bisphosphonate, oral bisphosphonate. So that is one of the issues with bisphosphonate. But really, has teriparatide been given for extended the duration for 3 years? The reason being the mechanism doesn't match with that, because by 18 months, the anabolic window, quote unquote anabolic window, is lost. That means the PINP level in the serum and the CTX level, the resorption marker level, they almost come together. So the advantage of its bone anabolic moreover resorption is lost by that time. So what is the point in increasing it till 3 years when your drug advantage is lost? So that is what I was thinking.
So two things, as you rightly pointed out. Denosumab, once you stop, the risk of fracture, vertebral fracture actually increases. So there is European guidelines saying if after giving denosumab for 2.5 years, if your risk in low risk category, you can switch to bisphosphonate. If you are in high risk category, continue denosumab up to 10 years. Actually, that's the guidelines. But again, it's guidelines. The other thing is whether, why they are making it 3 years. So they have done the studies recently and they have showed that the anabolic window actually extends more than that 18 months duration. Actually, they had to stop the trial when they were doing the trial because of the risk of sarcoma that they had seen in rat. So nowadays, that's what is coming up, that American guidelines are switching to 3 years. Europeans are still at 2 years. Yeah, as you told, anabolic window depends. So there are also in our center, actually the endocrine is looking at postmenopause. They are telling that anabolic window is actually longer in probably in Indians, and more data needs to be generated. Teriparatide may be helpful in a longer duration rather than 2 years alone. So that more data needs to come in. Thank you, sir.
Thank you so much, and we close the session.